Hi, this is Dr. Bhargava, and in this short video, I have several interesting cases to share with you. Here's our first patient. We performed a PET scan of the brain using FDG. And so let's start by looking at the rotating image. Pay attention to the posterior aspect of the brain, the occipital lobes. There is diffuse hypometabolism, as we see here on this axial image, including bilateral occipital lobes and preservation of the uptake in the cingulate cortex, also called the cingulate island sign. So this patient has findings suggestive of Lewy body dementia or Lewy body disease. This is a great review article on the topic of PET-CT imaging of dementia. Check it out. Here is the same patient who underwent a amyvid PET, and this axial image on the left shows it's a little bit count poor study, but we do see the differentiation of gray matter from the white matter uptake from the gray matter, and at the same level on the fused PET-CT image using the color scale for PET uptake, we find that it's easier to differentiate between the gray and white matter uptake. So here's the white matter with physiologic uptake, and here's the gray matter showing no uptake. And so this patient, this study is a negative amyvid PET study. Here's our next patient who underwent a whole body FDG PET-CT scan. Let's start by reviewing the rotating image. This image shows intense uptake in a peripheral pattern involving the right hemithorax, and we look at the corresponding axial images. We find that there is on the CT diffuse thickening of the pleura. There are some calcifications also, and this thickened pleura shows intense hypermetabolism. There is some subcarinal focal uptake from metastatic lymphadenopathy. So this patient has mesothelioma because there is symmetric pleural thickening, and that thickening is hypermetabolic. Of course, they need a biopsy to make the diagnosis, but FDG PET-CT is good for staging the disease. Here is our next patient. They have a similar appearance of FDG uptake in a peripheral distribution in the right hemithorax, and when we look at the rotating image, we find that this uptake here is a little bit more heterogeneous. There are multiple foci of increased uptake, and there is a lung nodule that is hypermetabolic from metastatic disease in the left lung. Let's also take a look at the fused PET-CT image in the coronal projection, and we find the same thing, heterogeneous, intense uptake in the right pleura with several foci of intense uptake. So this patient has pleural metastases compared to the one that we saw before who had mesothelioma. So frequently the lung cancer can spread into the pleural space, and when that happens, there can be drop metastases, so the cells can drop in the pleural space from the superior to the inferior aspect of the pleural space, and then they will grow there, becoming tumors, and these tumors will become or will be FDG avid. So when you see multifocal uptake in pleural masses, it is a pleural metastases and not a mesothelioma, which shows diffuse thickening of the pleura with hypermetabolism. And so this patient has pleural metastasis, and this is their coronal CT chest with contrast, showing multiple enhancing tumors involving the pleura. This patient's histology was adenocarcinoma that was previously removed, and it recurred and came back with pleural metastasis. This is a good review on the topic of FDG PET-CT's role in staging and restaging of malignant mesotheliomas. This is our last patient for this video. They also were diagnosed with lung cancer, and they underwent a whole body FDG PET-CT study for staging. Let's start by reviewing the rotating image. And so we see this large tumor in the left lower lobe of the lung. We see extensive hypermetabolic right hilar and subcarinal lymphadenopathy. And on these corresponding axial images in the lung windows, we find that there is a large cavitary tumor, and it shows intense peripheral hypermetabolism, and there is solid regional right hilar hypermetabolic lymphadenopathy. So this patient has a cavitary lung cancer. So what are the characteristics of cancer when it presents as a cavitary lung cancer? So the cavitation occurs because the tumor grows rapidly, outpacing the blood supply, and if there is a communication with the airway, it leads to air entry and air inside that cavity. Up to 82% of squamous cell lung cancers cavitate, less commonly adenocarcinoma. Our patient that we saw previously was diagnosed with adenocarcinoma, and small cell lung cancers rarely cavitate. Metastases from squamous cell cancers from the head and neck and also sarcomas can cavitate. The features of malignancies include thick irregular walls, spiculated borders, adjacent consolidation, or a surrounding mass and rapid progression of these lesions. Benign cavities can be seen with tuberculosis, fungal infections, lung abscesses, and some congenital lesions. Complications include superinfection, there can be hemorrhage inside, and if it communicates or invades the pleural space, there can be pneumothorax. This is a great review article on cavitary lung diseases, a clinical, radiologic, algorithmic approach. Check it out. Thank you for watching.